Next, I call upon Dr. Susita Amarasinghe, who is a consultant cardiac electrophysiologist at the Teaching Hospital Karapitiya, to talk about a very important aspect of atrial fibrillation management, which is prevention of stroke. Over to you.
Thank you very much, sir. Good morning, everyone. Within next few minutes, we'll try to concentrate on this important aspect of management of atrial fibrillation. I have a disclaimer. This talk, I'm going to focus on the my junior colleagues actually, so not for the specialists and the experts. First of all, can I ask you all a question? How many of you have seen or managed a patient with atrial fibrillation within last 2 weeks? Can I see the raise of hands? People at the back? Yeah, I see number of hands. Excellent. The second question is, how many of you have calculated the risk of stroke in these patients? Can I see? Actually, I see more hands now than earlier. Excellent. Very good. Right. So the objectives would be to discuss the significance of stroke and thromboembolism in atrial fibrillation, identify patients at risk, how to decide the best anticoagulation strategy for a given patient, how to assess the adherence and compliance in these patients, and when do we have to avoid anticoagulation, and what other alternative strategies we have. So why is it important? AF, as we know, increases the risk of stroke by at least 5-fold. And the strokes, when it happens in atrial fibrillation, is more disabling, which is disheartening. And anticoagulation is the only proven treatment in atrial fibrillation that is known to reduce mortality and morbidity. And it does it in a very significant way. And the previously used agents like antiplatelets have no place in preventing strokes in atrial fibrillation. And remember, it is still largely underutilized, oral anticoagulation. So it's a very important aspect that we need to keep an eye. You already saw this slide. So the ABC approach to management of atrial fibrillation, as per the latest ESC guidelines, the A stands for anticoagulation. Assess the risk of stroke and anticoagulation. So there are various ways of assessing the risk, we know. And it used to be CHA2 score earlier, now it's CHA2 score, and there are other number of risk scores. The idea is to identify the patients who are at risk using an objective tool. So I will just quickly go through this under each letter. The C stands for congestive heart failure or reduced ejection fraction. But remember, the guidelines vary a bit here. According to the latest ESC guidelines, if you see, that also includes patients with preserved ejection fraction, as well as patients with hypertrophic cardiomyopathy. You already heard, hypertrophic cardiomyopathy has a strong association with atrial fibrillation. And also remember, HCM or hypertrophic cardiomyopathy is not uncommon. So it's important association, right? And hypertension, all these get a 1 point in addition to age, where you get 2 points. One word about hypertension. Again, remember, hypertension is not just one figure. The higher the severity of hypertension, the higher the risk of stroke. Though the score doesn't give you that idea, remember, if you are dealing with a patient with higher hypertension severity, then the risk is higher. So same with age. Age is a continuum, not just one figure. So higher the age, higher the risk of stroke. So therefore, age is not a factor to deny someone of anticoagulation, right? And previous stroke, TIA, thromboembolism is a strong risk factor. Vascular disease, again, guidelines vary a bit here. You can consider peripheral vascular disease, even coronary artery disease, including angiographic proven coronary artery lesions, even without any ischemic heart disease, or patients who already had a myocardial infarction also comes under this category. Right, so other risk scores are also available, but we use that score. And what about assessing risk of bleeding? Before you decide on someone to implement a stroke prevention strategy, you have to strongly consider their risk of bleeding. So there are various risk scores as well. Again, commonest use is has bled. But what's the idea of this score? Is it to identify people who are at high risk and then avoid them or prevent them getting the benefit of anticoagulation? Certainly not. The idea of using a risk of bleeding is actually to identify those patients who are at risk, to keep them under more closer monitoring, as well as to identify those who have risk factors that we can modify to reduce their bleeding, actually. So never use a bleeding score to deny someone of anticoagulation. So actually, the idea is the other way around. Right. So these are available in all the guidelines. And so it's very simple. You just have to remember only one thing. The default is to start anticoagulation in atrial fibrillation until proven otherwise, except the lowest risk category, which is when the CHA2DS2 score is 0 in men or 1 in female. One thing you should remember is that female gender is a risk modifier, not a risk factor. When it is associated with any other risk factor, it becomes a risk factor. So basically, if it is 2 or more, you start anticoagulation. So guidelines slightly vary, but remember this bit is enough. So what do we have? Of course, in the Sri Lankan setting, more than 90% of the time we use warfarin. Warfarin is well proven, has strong evidence of effectiveness of reducing mortality and morbidity. And it's supported by a number of studies. What is the problem with warfarin? Warfarin is a very good drug as well as a very, very tricky drug. The reason is it has a narrow therapeutic range. So therefore, we need to keep a close eye when patients are on warfarin. And just checking spot INR is not going to give you assurance that patient is going to be having a therapeutic anticoagulation. Ideally, we need to calculate what is called TTR, or time in the therapeutic range. But what practically you can do is identify those patients who are likely to have lesser therapeutic INR and have a closer monitoring. So because of the problems with warfarin, number of agents got added on as time went by in the early 2000 onwards. And we have at least 4 agents now internationally, strongly supported with a lot of evidence. You probably know the landmark trials, Aristotle, Rocket AF, Rely, and Engage AF, each depicting these agents. The commonest agents these are called DOACs, or direct oral anticoagulants, used to be called NOACs. They are not new anymore, so we won't call it novel oral anticoagulants. So rivaroxaban, dabigatran, apixaban, and edoxaban. These are the agents that we can use. In Sri Lanka, already at least 1 agent is commercially available. Maybe 1 or 2 are coming up. So each of these have their own advantages and disadvantages. Warfarin still is a very, very useful drug with a lot of key advantages, including the least of the cost, and cheap availability of antidote, as well as availability of monitoring. So because of the limited time, I will not be going through each of these categories, but remember, it's not a one-size-fits-all type of management in these patients. We have to identify subcategories where you will have to decide on the ideal medication to use. So this was already discussed from yesterday, but remember, we keep seeing patients on single antiplatelet agent, or dual antiplatelet agents, and dual antiplatelet agents plus oral anticoagulants in various categories. The take-home message for you all would be, if someone is already having atrial fibrillation, the only reason why they need to be on dual antiplatelet plus anticoagulation is if they have had a recent onset acute coronary syndrome event or a recent intervention, cardiac intervention, in which case you will have to continue that maybe up to 1 month, maybe in some cases up to 6 months. However, beyond 1 year, if you see it, then it's likely to be inappropriate. So if you see someone being continued on all 3 agents beyond 1 year or lifelong, always ask the question, is it necessary? So these are the basic aspects that remember there's no place for single antiplatelet or dual antiplatelet in preventing strokes in patients otherwise do not have any indication for antiplatelets. So the take-home messages, always have the idea to assess their risk whenever you see a patient with atrial fibrillation. And remember, just assessing and labeling the CHA2DS2 score once is not enough. It needs to be reviewed every 4 to 6 monthly at least, because most of these risk factors are continuum and they keep modifying and they keep getting added up. And bleeding risk assessment is not to deny them of anticoagulation. It's actually to support optimal anticoagulation plus monitoring. Yeah, so whenever possible, the DOAC is a good option. Thank you very much.
Thank you, Sister, for that very important and elusive discussion on the use of anticoagulants. Can I now invite all three lecturers to the stage, because we'll start the case discussions, and you will be also part of the discussion as well. So, can we get some chairs, some further chairs into the stage? You could carry your own chair and come, I suppose. Okay. So basically, the case discussions, we have three cases discussed. Our senior registrars will be presenting the cases, and then we have time for discussion after each case, where we'll have comments from the expert, all the experts here, as well as opportunity for you to ask questions as well. So can I first ask Dr. G. Vasikaran, one of our senior registrars, to present the first case?
Good morning, everybody. We are going to present some cases which related to AF. This is the first case. This is a 45-year-old female. She had been referred from the medical ward with a history of the right-sided ischemic stroke for one-day duration. She is currently on antiplatelet as well as statin, which was managed from the medical team. And previously, she had one episode of palpitation with an episode of transient visual loss, which was 6 months back. And her transient visual loss lasting only 15 minutes, which had been extensively evaluated on that time. There's no other comorbidity. So initial investigation, which had been done 6 months back, non-contrast CT brain, which was normal. And initial Holter monitoring was reported from by EP team. There's no atrial fibrillation or flutter. And 2D echocardiogram, there's no LA or LV clots. And other investigation found to have normal, including thrombophilic screening. In this admission, patient had been underwent to MRI brain. There's a left-sided small multiple infarction, which involving the left side parietal as well as capsular region. We repeat the Holter. So this is a abnormal trans we can able to notice in this time in the Holter. So it's up to expert.
You got another Holter slide there?
Yeah. So these are the Holter reports. I mean, these are runs. These abnormal runs. It looks kind of atrial tachycardia. I mean, there's a atrial premature atrial trans. So it's look short runs of 80.
So basically, these are kind of situations that we come across very often, where we have patients presenting with episodes of transient ischemic attacks or even direct strokes, and we don't have much evidence, but we have this kind of atrial ectopic activity, runs of atrial supraventricular ectopics. And the question is now, can we diagnose AF on this clinical history? Can I ask from start off?
I agree, this is a very common clinical problem I encounter, because not a single day goes by without I see an AFib patient as much as an interventionalist see coronary artery disease every day. So in this scenario, first thing that struck me was it's a 45-year-old woman, which is unusual to get TIAs and amaurosis fugax type of symptoms. So obviously you think of atrial fib because I'm an electrophysiologist, but then there are other things you need to think, any hypercoagulable states and other reasons before going to AFib. But you do provide this clue, and obviously, other than that, other sources of thromboembolic disease, but echo was normal, so you don't suspect rheumatic valvular disease and all that. So assuming everything else came out negative, this is the only clue you have is short runs of atrial tachycardia. Now, this is important. I can't just disregard it. I don't have I mean, this can be even a longer monitoring. I may have a 30-day monitor, I still end up having same set of information. Sometimes not even these short runs of atrial tachycardia, you just have 10% burden of premature atrial complexes or 15%, just PACs. Now AFib. So, but then you, on the other hand, you have a young person with a stroke with multiple small cortical infarcts, and then you have these clues. Are you waiting for a perfect diagnosis? Probably not. And again, my rule of thumb is what if it is my sister or my mother or my brother? Because there is a strong correlation between these type of short runs and the development of atrial fibrillation, because these are the triggers for atrial fibrillation. We know that. But whether that's the case in this patient, we don't know. We haven't proven it. But then do you really want to monitor somebody who already had a couple of strokes for a longer period of time just to prove a symptom? I would not. I evaluate, already she meets the criteria for anticoagulation if you assume this is AFib, and if assuming a Hasbled score is low, I would consider anticoagulation based on this information. I don't have a randomized control trial to prove this, but I will have to sort of make judgment based on multiple observations at multiple places.
Thanks, Milan. Yeah, so the problem is now, so basically if you look at what Dr. Janaka presented, that now for diagnosis of atrial fibrillation, you should have at least 30 seconds run of atrial fibrillation or irregular heart rate. Can perhaps Dr. Asanga will comment on what other investigations we can now do to actually come to a very conclusive diagnosis of atrial fibrillation? Is there anything that is available for us?
Yes. I think the classic tool would be implantable loop recorder. It comes very useful in young patients, and elderly maybe you can probably make a clinical diagnosis to get this evidence across. Young atrial fibrillations are rather unusual, but it's not unknown. So therefore, we should make a careful diagnosis towards them. So the ILR is the classic tool. There are maybe other tools available like smart watches and things like that. If you have a symptom on site for us to detect certain things. So those other equipment Dr. Patiraj has described earlier would also come quite useful. The long Holter monitoring can be an asset. You know how cumbersome to wear a Holter for a period of 24 hours, though then we mention 48 hours, patients really don't like it. But then there are small patches with 3-lead Holters which can go on for weeks, which allows patients to have a good wash as well without the patch getting washed away. So that kind of longer duration monitoring will also be quite helpful. Yes, if the patient has a device, detection through the devices would be important as long as they are longer runs.
Vashi, can you tell what happened to the patient after that? I think we were considering trying to get a loop recorder, but it's very difficult to kind of access loop recorders here because it's not available freely and it's very expensive.
Actually, so we were awaiting for the ILR implantation to this patient. While awaiting the, so we have almost at least 3 months we have to wait for ILR implantation at here. So while awaiting for this period, patient can able to get down a device called Cardia. It's kind of a smart device. It's like a smart watch we can attach to skin. It's a single lead ECG monitoring. So patient can able to get down this device from USA, and while this period, patient developed one episode of kind of palpitation, and while she monitored the ECG through this device. So this this episode have been recorded in the that particular devices. So
I just want to ask this question. I just started feeling I was too aggressive in starting anticoagulation before waiting this to happen. I would still do, obviously, I like to and make a clinch the diagnosis, but this is a young person who already had 2 strokes. And I don't know when I will catch her atrial fibrillation. This probably fortunately caught it before 3 months, but that's more than enough to get another stroke. the person already having multiple strokes. So that's why I go to the principle, assuming I don't cause harm. Anticoagulation can cause harm, but you have to inform the patient and say, look, this is why I'm doing it. If you are going along with that, I would start an anticoagulation. It's sort of a parallel to, this is a patient, I mean, if you think of coronary artery disease, this patient already has multiple small infarct. And do you want to prove cholesterol level before you start a statin? You do start a statin regardless. And that kind of feeling I have. I don't have data about what I'm saying is that the patient already had strokes. So I would go for it. If a patient didn't have strokes, I would certainly clean the diagnosis before I started. That's the difference. And again, that's an opinion only.
Yeah, I think I completely agree with Dr. Mevan on that concept. Just two facts I'd like to highlight. One thing is CHA2DS2-VASc score, while predicting risk of stroke in these patients, actually it can predict the occurrence of AF also. CHA2DS2-VASc, if we calculate CHA2DS2-VASc score for this patient, the presence of AF, I mean, it will support the possibility of AF in this patient, apart from the high stroke risk. That's one thing. Also, we need to understand that 30-second definition is not for patients who already have an ischemic event, thromboembolic event. When you have a thromboembolic event in the patient, that really change a lot of things, because we don't want to wait for a massive stroke to start anticoagulation. What we gather from these short runs are that we know the substrate is there in the left atrium. And we know in atrial fibrillation, it's not only the rhythm, it's the atriopathy of the left atrium that matters. So anticoagulation actually is to manage the atriopathy with prothrombotic situation of the left atrium.
It's always a question. It's all a problem because we think that we need to actually demonstrate that there is atrial fibrillation before starting anticoagulation, and particularly if you use CHA2DS2-VASc score. So that's kind of situation because it is not recommended to use a CHA2DS2-VASc score unless we actually diagnose atrial fibrillation on the diagnostic criteria. But I think I agree entirely with what you are saying. And also it's interesting now that we have more ways of diagnosing atrial fibrillation with these various devices. I think Dr. Janak can you kind of mention other ones that we have, like the Apple Watch? And some of these are, mind you, FDA approved as well. Yeah. So, you got comment on it?
Excuse me, can I ask a question? Can I ask a question?
Yeah, of course.
Now, actually, good patient. Now, we see this day to day. Now, in the absence of structural heart disease, if it is a LA is dilated, then of course, then we can pretty clinically sure that it's likely to be a paroxysmal AF. But in this case, left atrium also not dilated. So, of course, now when we do monitor Holter in these patients, actually we see the episodes of atrial tachycardia and sometimes frequent atrial ectopics, right? So we don't anticoagulate, but of course we put on antiplatelets and send. So what are the clues that you will say this patient is at a risk of AF, or the AF is likely in the absence of AF, like atrial ectopic is a feature that you consider, and what are the things that you look in the Holter and say, this patient is more likelihood getting a AF by just looking at the Holter?
So that's exactly right. The proof is a couple of ways I can say. There are studies to show that if you have increased atrial ectopy burden, your stroke risk is high. But again, remember, these patients are not monitored continuously. You get a batch of patients who have atrial ectopy, and then you don't monitor them every day, but then you know their stroke risk is high. Maybe in between they get AFib. That's possible. But we also know that atrial ectopy, atrial tachycardia are the triggers. What we don't know is whether this particular patient, it's like that. That's what I'm coming at. So do you want to wait until you prove that gap? And I would not wait until that, because the patient already had strokes, right? And if the patient didn't have a stroke, but your young woman, the young woman had a stroke, but no palpitations, no ectopy, I think it's very reasonable to monitor long term and to catch, assuming you didn't find anything else to prove that she had a stroke from another source. Because in a young person, you are not expecting AFib to be the primary cause of a stroke. There could be anything. I mean, even if you can stretch the argument, you can say you have a big PFO or something like that, causing paradoxical embolus or whatever, or hypocoagulable state or anything like that can causing stroke. But Did I answer, Dr. Ranasinghe, your question?
Yeah, I think there were few instances where, in fact, where everything was normal. In fact, I have detected atrial myxomas, attached to the interatrial septum. In fact, I showed yesterday a case as well. Everything was negative. But finally, 2 strokes, but then there's a small, we could not see from the TTE, but transesophageal echocardiogram showed there's a myxoma. Very rare cases, but can possible, yeah.
So I have a question to Dr. Mevan Wijetunga. Now, provided this patient, so without this cardia, so we saw a whole lot of atrial ectopics, maybe short runs of atrial tachycardia, and if provided this patient is someone who is having repeated episodes of palpitations, there's no demonstrated AF. When would you offer him an EP study? Because this could well be someone 45-year-old lady who is someone who is having AVNRT, something like AVNRT, and going into atrial fibrillation.
That's a very good question. So what Dr. Kotegoda is asking is, now this patient seemed to have atrial fibrillation.
Except, provided this is not available, is cardia.
Yeah, cardia monitor. Okay. So, and in young people, when you presume they have atrial fibrillation, you suspect there could be another type of a supraventricular tachycardia triggering. Now, atrial tachycardia could be a trigger. Same way, AVNRT type of supraventricular tachycardia could also trigger atrial fibrillation. Or it could be WPW that's triggering atrial fibrillation. Younger the patient is, you look for the secondary cause. Parallel example is, think about high blood pressure. Anybody over 50 years age, you don't look for secondary causes. But if somebody is 20 years age, 30 years age, hypertension, you look for secondary causes. So in EP, if a younger person gets AFib, we try to see whether there is any preceding arrhythmia causing AFib. That is called arrhythmia-induced arrhythmia. And usually this could be any type of SVT, AVNRT, or WPW related, or even atrial tachycardia. It's fair. In this patient, who just had 2 strokes, I don't know whether I jump in to introduce catheters to the heart right away. I would anticoagulate the patient in this case. That's my personal preference, and make sure patient is stable for a few months. Then it's reasonable to do an EP study, because you may find another tachycardia that is more amenable for curative treatment with ablation that could potentially trigger AFib. Wonderful thought.
To add on to, if a younger patient gets atrial fibrillation, please make sure that the thyroid functions are normal, and also the fact that whether the patient has had alcohol within the previous 2 days. It is a common scenario we come across here. They go to a party and have either binge drinking or excessive drinking, so that breaks into atrial fibrillation overnight, and we see the patient acutely. So it's a pretty common scenario.
Yeah, thank you. So that was quite a nice discussion about this patient. Thank you, Vasi.
Thanks.
And can we have Dr. Mahendra? So for the second case, this is quite a very simple case, but I think we can come to quite a nice, interesting discussion with this case.
Good morning, everybody. Having a very good comprehensive update about the rhythm management, I wish to present a case of a simple looking case, but it is a tricky case. We had a referral from a neurology unit about the 80-year-old patient who is presented with the slurring of speech and deviation of mouth to the side, with past history of 2 similar episodes, and with history of comorbidities with type 2 diabetes for 10 years and dyslipidemia. And while referring the patient, he had been started aspirin as well. And this is the 2 ECGs taken apart from few hours. And the question we had to answer was whether the available information is adequate enough to advise about the rhythm, whether it is atrial fibrillation, atrial flutter, or what kind of management we should advise regarding this patient?
Okay, so basically, it's not an uncommon kind of ECG that we get. Right? Perhaps Suresh, should you like to comment on the ECG?
It's a irregular, narrow complex, irregular wide complex rhythm with a prominent R wave in V1. So it's a right bundle branch block pattern, and no real obvious P waves, and the baseline is quite busy. It's like a fibrillary type of baseline, and so. Yes, and when the baseline, it looks, when you see those waves, actually they are pretty polymorphic. They are not similar to one another, because in atrial flutters are single circuits. They are fairly large circuits. We call them cavo-tricuspid isthmus dependent, counterclockwise or clockwise. It goes on the same path, or sometimes it can be left atrial flutters, mitral annular flutters, roof flutters. So they go in the same path. Whereas atrial fibrillation, they have a lot of multiple wavelets. So a large number of electrically active foci, which are firing at all different times and places. So hence, it will be we call it polymorphic. Those waves will not be similar to one another. So this is a atrial fibrillation, coarse atrial fibrillation.
And
what about?
And we are looking for P wave activity in lead 2, 3 AVF, inferior leads and V1.
For instance, the first ECG, the bottom strip, right? There's a variation. There's a variation AV conduction, and whether the end of that shows something like a atrial flutter there.
Yeah. I think at our level we would go for atrial fibrillation, but since the ECG is not on my hand, I can't exactly say. There is flutter-like activity in the second ECG. Whatever it is, the management would not going to change here. That's the bottom line. Both AF and atrial flutter, anticoagulation, decision on anticoagulation won't change on the diagnosis. But the management would change, long-term management would change. We can offer ablation in our setup for flutters, whereas not in atrial fibrillation.
Yes, so things you can see that even 7 electrophysiologists can be quite confused about this, so it's not always easy.
I think the best I heard was when I couldn't see it well. Very young colleague said he couldn't see it either, so I felt good.
Well, yeah, we all need spectacles by now. Yeah, so this is always a question whether it's atrial flutter or fibrillation. But as Manu said, it doesn't really matter because both the management is still the same. Now, I don't know whether the guidelines are very clear about the fact that you should manage when it comes to anticoagulation, whether it is usually the same parameters with atrial fibrillation, atrial flutter. What's the kind of thing on that? Because when we talk about atrial fibrillation guidelines, they don't really talk much about atrial flutter, do they?
So in this, I totally agree with this, because whether it's atrial fibrillation, whether it's coarse atrial fibrillation versus atrial flutter, this is a semantic thing, and you can argue. But ultimately, they are all, the way I see is this. Some patients, particularly young people, just have atrial flutter, and that's the way Dr. Kotegoda said. They have a fixed electrical macro circuit going on, usually on the right side. So when it goes around, and that gives you this typical sawtooth pattern, because each sawtooth represents one round, and it's the same circuit. And we love to see the same circuit because they can ablate and you're done. That's atrial flutter. But the same condition that predisposes the patient for flutter will predispose the patient for fibrillation as well. So in some patients, we see only fibrillation, which is very chaotic. Some patients, we see flutter only, but then in majority, we see both. And I have seen patients, when you look at the catheter, in right side, they are in flutter, left atrium is in fibrillation. And that's how it is. And so when we split hairs whether it's fib or flutter, sometimes it just doesn't matter. And the treatment-wise is the same. Chad-Swatsky is the same. That's what the guidelines suggest. Because once in a while I come across colleagues who claim that flutter is benign, has less risk of clots. And these are educated colleagues. Now, I'm not saying I'm right, but the guidelines have suggested that I should treat flutter, the stroke risk, the same manner like the stroke risk of AFib. So I don't, at least until somebody proves it, otherwise I would not, I would consider as an equal risk of stroke, at least to consider that way. And then in this patient, had just had a stroke, pretty paralyzing stroke, 8 years age, so whether I should consider ablation urgently, that's a different question. But at least assuming the stroke is not huge and there is no immediate hemorrhagic conversion, you may want to talk to the neurologist and see when we can start anticoagulation with that.
Yes.
One more thing. The patient is 8 years old and there is also right bundle branch block in the background. This could be part of sick sinus. So we need a quick Holter to verify that. Because if you have a sick sinus, you might need to put a pacemaker first before starting on anticoagulation. So consider the sick sinus, especially in advanced ages, because you really can't afford them to have a fall with anticoagulant.
I think that's another point here. Now, basically, we find that very often, particularly when it comes to neurologists, they start on antiplatelets rather than anticoagulants, and which we know is not as effective. And one kind of excuse is always 8 years old, he might fall and he might have ICH. But what do you think about this, Asanga? What do you think that, whether we should, whether age really matters when it comes to the need to start oral anticoagulation?
Yes, of course. Like most of the neurology referrals we see are in their advanced ages with atrial fibrillation that straight away says that we should be starting anticoagulants. How fast we can do a Holter depends on a few factors, I guess. And but anticoagulation is almost immediate. But if you can get a Holter monitoring done, at least for the safety sake, that would be very useful.
Other thing is because now what they have found is basically that the risk of stroke is higher than the risk of fall and ICH. So unless patient actually has some other disabilities, gait problem and things that gives a higher risk of having a fall, there's really no indication not to start oral anticoagulation. I think Keith wants to say something.
I want to ask, what is your take on restoring the sinus rhythm? Would you advocate on restoring sinus rhythm in her case?
Again, I think still the immediate question is the anticoagulation, because that is the biggest harm to this 8-year-old person, and whether you can start it, when to start it safely, because you don't want to do it just because her Chad-Swatsky is high. Once it's done, then you go to this ABC management, and can we improve her lifestyle? Again, my take on is, what if it is my mother? And because there's no study on this patient, how I should manage. All I can tell you is this. So then if you want to restore sinus rhythm, now that's a separate issue compared to what she is acutely sitting. I like her to, of course she doesn't look like in a significantly rapid heart rate. Okay, so it doesn't look like, okay, this is just a spot, few seconds of her life. I need to get a better idea that she is tachycardic or not. So in that case, since she is still acute or in the convalescent period of a stroke, I would not, in an 8-year-old woman, I go slow. There is no rush if she is not symptomatic. If you want to add a beta blocker or something to slow down, I am not against. Then you reassess the patient. I don't know what the patient is going to be. She may be paralyzed half. She may be bedbound for the rest of her life, cannot speak. What do I gain to her by cardioverting? That's the way I look at it. And I might give a beta. We can always slow down the heart rate with a drug, calcium channel blocker, beta blocker, and if she's happy, whatever happiness is, and then anticoagulation, hopefully we do no harm. Now, if it is somebody who is very energetic, wants to get back to life, and want to live until the last day, they breathe on this earth in that way. There are people like that, very elderly, but they want. And then you can have the dialogue, what else you need to do to restore sinus rhythm and move on. So it's a tailor-make decision, no, I can't say there's a one-size-fits-all. Because when you do that, I feel good about what you're doing. Sometimes what we do can harm people, whatever we do, whether it's a drug or a procedure. So, but if it's that kind of a decision, we both know what we are trying into, and that gives us a better feeling that we are part of a, something good we try to achieve with that. Does it make sense to you? I didn't give you a straightforward answer to that, but that's what the life is often.
I think it's equally bad getting risk of stroke without knowing the duration, because it's overuse of amiodarone, and also patients are on a lot of amiodarone pills post-op. Would the expert panel can advise on that? Because we have seen that most of the time, straight away amiodarone infusion is on board when the patients come to emergency. If you can convey that message, what is your protocol and how do you sort it out, that would be.
I think that's a kind of huge discussion on its own. Basically, that is treatment of acute AF, how to set about it. A lot depends on the duration, and when the AF actually started. And because we know that there's this so-called 48-hour window where if within that time the AF started, then the risk of cardioversion is low, the risk of stroke during cardioversion is low. Otherwise, when we had to do a plan, so and also we know that whether you go for rhythm control or rate control, there's not much of a difference. There are no large studies showing that rhythm control is much better than rate control. So that is one issue. And also remember that some patients are quite okay with in atrial fibrillation. They may be asymptomatic. And so therefore there is no rush to convert to sinus rhythm unless there is some other indication, like maybe they're in heart failure and you want to get back into sinus rhythm. So that impetus to kind of really go for to cardiovert is really not there always. I think we are kind of...
One more thing, just in addition to anticoagulation, if you are to start on an antiplatelet for a long run, what would you prefer? And in the anticoagulation also, if you're going for Novak after the age of 75, what would be your recommended dosage? So it's like therapeutic or subtherapeutic, or what that you should achieve?
So basically, if it's only atrial fibrillation we are talking about in this patient, there's no real indication for antiplatelet agents, only anticoagulant. But if there's a mandatory indication for antiplatelet, like a recent acute coronary syndrome or a history of PCI, in that case, if it's stable coronary artery disease we are talking about, it's only a single antiplatelet we need together with oral anticoagulant, in which case P2Y12 inhibitors are the preferred agent, not aspirin. So clopidogrel in our setup together with warfarin would be the ideal in the long term.
I ask this question because most of these patients who are already on an antiplatelet coming with AF and a stroke, then you need to add the anticoagulation to that patient.
Sure, definitely, yes.
Yeah,
clearly, antiplatelet will not have any significant protection for atrial fibrillation.
And the anticoagulation at the therapeutic level, or you go in a subtherapeutic level?
It will depend on why the patient was on an antiplatelet in the first place. So if that antiplatelet are needed for that patient, particularly say if I had a recent PCI and a stent, then you have to continue the antiplatelet. So therefore you are talking about dual therapy, right? But if the patient, we know that in Sri Lanka, a lot of patients are on dual antiplatelet without any reason at all. Say he had a myocardial infarction or a non-STEMI 6 years ago and they're still on dual antiplatelets. So in that situation, we have to be very careful on starting oral anticoagulation, because we know that dual antiplatelets are not protective as for the stroke, as in atrial fibrillation. So we need to convert them to oral anticoagulation and get rid of the unnecessary antiplatelets if they are not really not needed. That's the kind of, I think that...
Also, about the dosage, the question you answered, there's actually a lot of guidelines strongly advise against using suboptimal dosages. I mean, if you are taking the risk of starting anticoagulant, you have to be starting it at a therapeutic level, in which case reduced dosages only for categories of CKD with low gradient clearance or liver cell disease, that type of situations. But in this situation, you have to go for the optimum therapeutic dose, even for DOACs. Only issue we have is we don't have our local data. We don't know what is the right dose for our population. But we still go with the Western guidelines. That's where our limitation.
I would want to say that now that there are two direct oral anticoagulants available, dabigatran and rivaroxaban. Rivaroxaban is actually quite economical. I think the 10 milligram tablet is about 150 rupees and 15 is about 180 to 190. So, and the 20 is a little more than that. For answer to Stanley's question, I think if you are thinking of an in-between dose, start with 15. If the patient is thinly built, go for 10, right? And but in other cases, you should go for 20. We are talking about rivaroxaban. Dabigatran that is available is 150 that is available here. You look at the renal function, and then the standard dose is 150 twice daily. I don't think the 110 has also been used in India quite efficiently, but I don't think we have the 110 tablet here. 150
We have
is
110.
110, I think, is a safer dose in the Asian races and for the older people.
Yeah, this question came up because these patients were vulnerable to have falls. So the patient goes to a neurologist, and the neurologist says to reduce the anticoagulation. And because of the falls and the risk of hemorrhages. And one of these patients ended up with the acute SDH and to end up with the Burhol.
Okay, then we'll terminate this discussion for this particular case. Thank you, Mahendra.
Okay, thank you, sir.
Yeah. And the last case, we'll call upon Dr. Kalani Gunasekara. Now I'm getting confused. Gunaratna, sorry. Can you come forward and we'll ask? Yeah, after a very long time, actually, we are having a lady coming to do electrophysiology, and we are welcoming her very much. So. Yes, yes. We have been accused of being all male, group in the EP, but now we have proved that we also have females as
well. Good morning, everyone. Here we come to the third case. Our case vignette is a 56-year-old female with hypertrophic cardiomyopathy coming with shortness of breath and chest pain. This is her timeline. In 2010, she was diagnosed to have hypertrophic cardiomyopathy with intermittent LVOT obstruction. At the point of diagnosis, her LV ejection fraction was 50. 1 year after that, in 2011, she had a 2-to-1 AV block, and due to that, she underwent a dual chamber permanent pacemaker insertion. In 2016, she had a ppm generator change, and by 2022 April, she has got several episodes of non-ST elevation myocardial infarction. And at this point, her ejection fraction was 35 and also complicated with several episodes of non-sustained VT as well. At this point, her coronary angiogram revealed normal epicardial coronary arteries. Considering all these criteria, she underwent ICD upgrade in 2022 September. She came to us 6 weeks after that on 18th of October 2022 for the first implant device follow-up. During that programming session, we did not encounter any NSVT episodes, any VT episodes, and there weren't any atrial high rate episodes also. She then admits to a medical wards 4 days after that programming session with these complaints. She comes with shortness of breath for 5 days duration and on and off chest pain. Her troponin I was troponin I revealed positive, and she was treated as per a non-STEM in a medical ward. On the 3rd day of her illness, she developed acute limb ischemia. She had bilateral lower limb numbness, and there were absent bilateral femoral pulses. She underwent urgent bilateral femoral artery embolectomy and started on IV infusion of heparin 1000 units per hour, and also commenced on warfarin as well. On the 4th day of admission, she also experienced a left eye monocular visual loss, which was of acute onset, and same day she has experienced an occipital headache, but apart from these two, there was no other focal neurological deficits. She was taken over to our unit on 27th, like on her 5th day of illness, and this is her NCCT brain. So I hope you can see she has she got a large right-sided parietal ICH, and same day we were able to get on her CT aortogram also because she had bilateral femoral artery embolism, and this CT showed there was CT evidence of superior mesenteric artery and left renal artery embolism, most likely due to thromboembolism. And this was a coagulation profile. Her APTT was more than 180 and INR was 2.43. And then we took another reprogramming session on her because of this high burden of embolic events. This was the EGM, the intracardiac electrogram we recorded during that reprogramming sessions. The upper line shows the atrial rate, the lower line shows the ventricular rate. I hope you can see the atrial rate is quite faster than the ventricular rate and is irregular, so which is showing atrial fibrillation.
Yeah, so this was a very difficult clinical scenario. So on the one hand, she has an ICH. On the other hand, she has multiple arterial thromboembolism, and the device has shown that there's possible of atrial fibrillation going on as well. So this is a situation where we need to anticoagulate, but then the question of the ICH is there as well. Mevan, we have been discussing this among ourselves as well and deciding what to do. So it might, if your input might be very helpful.
Yeah, this is a tough scenario, and because this patient had a peripheral embolic event, and which obviously can be related to atrial fibrillation. Another thing is like complex even from hypertrophic cardiomyopathy viewpoint, because she has now what I assume what we call a burnout type of a myocardium. Her ejection fraction is going down. And I wonder whether this troponin elevation was something like what they call a MINOCA, like epicardial coronary arteries were normal, but still she has elevated troponin before what was called non-STEMI. So it's a complex patient. And then she has thrown her clots down inferiorly, rather superiorly. At least she didn't get a stroke. I've seen renal emboli, and I've seen superior mesenteric artery, like acute bowel ischemia, and obviously several peripheral emboli as such. So now we have atrial fibrillation as well. So again, I would somehow, if time and circumstances allow, I will rule out hypercoagulable state, hematology consult. But the patient is already on anticoagulation recently, so it may hamper the anticoagulation, hamper the coagulation investigation. So now then I assume this atrial fibrillation is directly related to her thromboembolic events, but then she has an ICH. So one other thing is that there is a lot of controversy among the neurologists or neurosurgeons. If you had a bleeding today, obviously nobody is going to start you on anything, heparin or anything today. Can you do it in about 3 days, depending on the expansion of the size of the hemorrhage? Now, there you do with experience and guts without any studies. Generally speaking, how do you salvage? Do you salvage the brain or do you salvage the limb? I mean, that's the kind of a thinking you have. So in certain setup, you can start anticoagulation on this patient. Maybe not heparin right away, but maybe preferably a DOAC. If it sounds like you don't have access to apixaban, and that is said to have a less risk of cerebral bleed compared to the others. But you can use a DOAC, probably preferably over warfarin. Again, there is no guarantee. And if she has expansion of bleed, you are in trouble. Warfarin, you can argue, you can reverse it, at least if there's a problem. But it's a step I undertake in the absence of any guidelines with a neurologist to start it. And then see whether it works. Now, in my world, what happens is these are the patients I would ultimately consider for left atrial appendage occlusion. Again, considering it's a young woman, has a lot of life in front of her, not acutely, but cautiously evaluate her, assuming left atrial appendage is one of the major source of thrombi in AFib. You can go and occlude it with a closure device, like trade name is a Watchman or something like that. But again, it's not acute. That's a long term. But even if you put a Watchman in this patient, I still have to anticoagulate the patient for about 45 days until the endothelium covers the Watchman device. So that's a long-term option. But there is a lot of room for argument here when to start anticoagulation safely, preferably a few days later.
Thank you, Mayor. Yeah, that was, So that was a problem. We were suspecting probably that the reason for the the bleed was that we had to start on heparin on top of dual antiplatelets. So that was So we are running out of time now. So thank you very much for everybody for participating in this session. And thank you, Kalani. So we'll end up here.